Hello and welcome to today's Center for Healthcare Strategies webinar, made possible by the Kaiser Permanente Community Benefit, on lessons from the front lines, insights into trauma-informed care for Medicaid's complex populations. Before we get started, I'd like to quickly go over a few logistics. To eliminate background noise, phone lines are being muted during today's presentation. There will be 2 question and answer sessions held during the event. You may submit a question online anytime by clicking the Q&A icon located in the drop-down menu of the toolbar at the top of your screen. Instructions are shown on the screen at this time. Today's event will be recorded and shared publicly on chcs.org. I will now turn the webinar over to Alexandra Mall, Program Associate at the Center for Healthcare Strategies.
Hello, everyone, and welcome to the Center for Healthcare Strategies webinar, Lessons from the Front Lines, Insights into Trauma-Informed Care for Medicaid's Complex Populations. This webinar is supported by Kaiser Permanente Community Benefit. My name is Alex Mall with the Center for Healthcare Strategies, and I am delighted to be with you all and lead today's webinar. So during today's call, we will provide an overview of trauma-informed care, its relevance to the field of complex care, and the work that CHCS is doing within this field. We'll then hear from Lori Lockhart, who will share the work that Care Oregon has done to build a trauma-informed workforce, including outlining successful practices for hiring, training, and supporting staff. We'll also hear from Victoria DeFiglio, who will highlight the work that Camden Coalition of Healthcare Providers is doing within this space, as well as some of their cross-sector efforts to create a trauma-informed community in Camden, New Jersey. Questions will be addressed following each speaker's presentation, and we encourage you to type questions in the question box throughout the webinar. So my name is Alex Mall, and I'm a Program Associate here at the Center for Healthcare Strategies. I work with our Complex Populations team on both children's health quality issues, such as childhood obesity and children's oral health, as well as our adult health initiatives, including our Complex Care Innovation Lab and a new initiative around advancing the adoption of trauma-informed approaches to care. Prior to joining CHCS, I worked in maternal and child health education and policy in Los Angeles and Washington, D.C. I have a master's in public health from the UCLA Fielding School of Public Health and an undergraduate degree in human and organizational development from Vanderbilt University. So I'm also pleased to introduce today's speakers, Lori and Victoria. Lori Lockhart is the manager of the Health Resilience Program at Care Oregon and has collaborated with over 24 primary care and specialty clinics to embed a health resilience specialist and develop new workflows to incorporate this unique workforce. She has over 30 years of experience as a clinician, manager, and consultant in a variety of care settings. And Lori has also provided trainings on group therapy and trauma-informed care for the Institute for Health Improvement, Oregon Health Authority, health plans, primary care clinics, to name a few. Lori has a master's in psychology from Portland State University and has her license as a licensed professional counselor. Victoria DeFiglio is the Clinical Director of Cross-Site Learning and Workforce Development at Camden Coalition of Healthcare Providers. She guides their population health and super utilizer work through bidirectional learning with technical assistance sites across the country, as well as engineering curriculum to prepare the future workforce to engage with vulnerable, complex populations. Prior to joining the coalition, Victoria served as a Teach for America member where she taught high school science in St. Louis. She is a graduate of Simmons College and Goldfarb School of Nursing and is currently pursuing her master's in healthcare administration at the University of Pennsylvania. So just to give you a bit of background about CHCS and who we are before we get into the meat of the presentation, CHCS is a nonprofit health policy resource center dedicated to improving the health of low-income Americans. CHCS was established in 1995 through a major grant from the Robert Wood Johnson Foundation, and our work is centered around advancing the access, quality, and cost-effectiveness in publicly financed healthcare. To achieve our mission, CHCS works with states, health plans, and federal policymakers, focusing on enhancing access to coverage and services, advancing quality and delivery system reform, integrating care for people with complex needs, and building Medicaid leadership capacity. So CHCS has recently begun some new work and several initiatives to advance trauma-informed approaches to care. Through support from Kaiser Permanente Community Benefit, CHCS developed a complex care innovation lab to bring together leading innovative thinkers from 13 organizations across the country who are really making strides in improving quality and cost-effectiveness of care for complex populations. And within the Innovation Lab, a small subset of organizations were really interested in exploring trauma and pursuing training around trauma-informed care. These organizations are currently undergoing formal training in Seeking Safety, which is a trauma treatment, and a small subset are also training in eye movement desensitization and reprocessing, also known as EMDR, which is another evidence-based trauma treatment. And CHCS is facilitating the collection of feedback around these trainings to share learnings with the larger Innovation Lab group, as well as inform next steps in this field. So we also want to let you know about a few resources that are available also as part of the Innovation Lab and with support from the Kaiser Permanente Community Benefit. CHCS has also released an issue brief this past March entitled Trauma-Informed Care, Opportunities for High-Need, High-Cost Medicaid Populations, as well as a resource document with relevant tools and articles, and a blog post written by one of today's speakers, Lori Lockhart, outlining Care Oregon's trauma-informed approach. These resources can be found on the CHCS website, www.chcs.org. And lastly, with support from the Robert Wood Johnson Foundation, CHCS has launched a new 3-year initiative to increase the understanding of how trauma-informed approaches can be implemented in the healthcare sector to improve patient outcomes and decrease costs. Through this initiative, CHCS will work to build awareness and understanding of the impact of trauma and the importance of trauma-informed approaches to care among providers. And this work includes an environmental scan to identify best practices and key ingredients of successful implementation, as well as a multi-site demonstration across diverse delivery settings, extensive technical assistance to participating pilot sites, a learning collaborative, and a robust dissemination strategy to share findings. So we're very excited about this work and look forward to sharing more in the future. So I will now talk a little bit about trauma, trauma-informed care, and its relevance to the field of complex populations. So what is trauma and why does it matter? So while there are a variety of terms and definitions used for trauma, we find it helpful to use a framework defined by the Substance Abuse and Mental Health Services Administration, SAMHSA, saying individual trauma results from an event or a series of events or a set of circumstances that's experienced by an individual as physically or emotionally harmful or life-threatening, and that has lasting adverse effects on the individual's functioning and mental, physical, social, emotional, or spiritual well-being. Some of you may have heard of the Adverse Childhood Experiences Study. So this landmark Adverse Childhood Experiences Study, also known as the ACEs study, as well as many studies that build on the original ACEs research, demonstrate that the more an individual is exposed to adverse experiences such as physical, emotional, or sexual abuse, neglect, discrimination, and violence, the greater the risk for serious health problems and health risk behaviors, including depression, heart disease, liver disease, sexually transmitted diseases, smoking, alcohol abuse, and illicit drug use. In addition to the elevated risk of negative health outcomes, childhood trauma is also linked to detrimental social outcomes and increased costs to social service systems. As more and more research becomes available, experts are finding out more about the neurobiology behind toxic stress and how it really influences the development of the brain, as well as how changes in a child's development will affect the trajectory of his or her health and social, behavioral, and emotional health throughout the child's life. So what is trauma-informed care? A helpful framework for thinking about trauma-informed care is SAMHSA's definition that states that trauma-informed care, or also known as a trauma-informed approach, realizes the widespread impact of trauma and understands potential paths for recovery, recognizes the signs and symptoms of trauma in clients, families, and staff, responds by fully integrating knowledge about trauma into policies, procedures, and practices, and seeks to actively resist re-traumatization. So trauma-informed care acknowledges that in order to provide effective care services, the care team needs to have a complete picture of a patient's life situation, so both past and present. And this approach shifts the focus of healthcare professionals away from a framework that asks, what is wrong with you, to one that asks, what has happened to you? Trauma-informed care recognizes that much of the behavior demonstrated by individuals with a history of trauma developed as coping mechanisms to help people deal with trauma, and suggests that appropriate treatment can actually retrain the brain to respond to situations in a healthier way. It also acknowledges that the care delivery setting itself can unintentionally re-traumatize individuals and strives to create an environment that is sensitive to this for both patients and staff. Establishing a trauma-informed care framework or lens or mindset is a really important step for our organizations to reorient their culture and create an environment that supports trauma survivors. And it's important to note that trauma-informed care is both organizational and clinical. So while culture change and organizational change is necessary to become trauma-informed, evidence-based clinical interventions are also part of the clinical framework to address trauma-related symptoms. Trauma treatments or interventions like seeking safety and EMDR that I mentioned a few slides back, they can be used by themselves but may not constitute trauma-informed care. They are an integral part of an overall framework for trauma-informed care. So by recognizing trauma as a possible determining factor of serious health problems and health risk behaviors throughout the lifespan, and by practicing within a trauma-informed care lens, particularly in conjunction with access to trauma treatments or interventions, providers can more effectively engage and treat their patients and potentially help reduce avoidable utilization and excess costs in both the healthcare sector and social service systems. While the experience of trauma crosses gender, socioeconomic, ethnic and racial lines, many complex Medicaid beneficiaries display symptoms associated with trauma and are challenging to engage due to a range of physical health, behavioral health, and environmental circumstances. These individuals are typically frequent users of emergency departments, have higher disease rates, higher rates of substance abuse and behavioral health disorders, and poorer social outcomes that all show as symptoms of trauma. Healthcare organizations and delivery systems serving this high-need, high-cost population are increasingly recognizing the prevalence of trauma among these individuals. Using trauma-informed care to better engage with this difficult-to-reach population may help providers and case managers build a trusting relationship with these individuals and has the potential to enhance quality and cost outcomes for the Medicaid program overall. And lastly, we want to acknowledge that this is an emerging field in many respects, and we found that most experts agree that more data is needed for how trauma-informed care can be provided for complex populations. So we will now hear from Lori Lockett with Care Oregon, who will share the work that Care Oregon has done to build a trauma-informed workforce. So Lori, I will hand it over to you.
All right. Thank you very much, Alex. You did great, laid great groundwork, foundational groundwork for me. Next slide, please. I appreciate the introduction, and let me start. Since you already gave the definition, this is just to highlight, again, that we're all on the same page about understanding what trauma-informed care is. And today I wanted to focus on the 3 central principles of trauma-informed care and how we are applying that to our workforce. I might interchange client and patient at times because of the mental health background and world we tend to call our individuals clients. However, since my staff is embedded in primary care clinics, we use patient too. So just they're one and the same. We developed our workforce in accordance with the 3 principles of trauma-informed care. Creating safety, meaning physical safety as well as emotional safety, which obviously is built by establishing trust, a trusting relationship, which you do through offering choices, having transparency with leadership, and predictability. It's really important to know when meetings are going to happen, when you can count on people. Is someone going to show up when they say they're going to show up? Restoring power. certainly that's involved with so many of the underprivileged and the people living in poverty that we work with. But I've also found that it applies to the workforce. We've hired many people from community mental health and other social service agencies where they didn't have much power. And again, that's about providing choices and teaching skills. Finally, valuing the individual, which is done through collaboration, acceptance, being non-judgmental. We know that being judgmental changes the way we treat people. As the ACEs study, which was mentioned by Alex, by Felidi, and Anda in 1998 demonstrated, experiences of adversity occur across all socioeconomic, cultural, ethnic boundaries, so that we are just as likely to be working with a colleague with an ACE score of 5 than serving a patient. So next slide, please. I want to share the story of what we've learned by intentionally building a program from the ground up. I was delighted to start working at Care Oregon 4 years ago to develop this program and have the opportunity to start hiring people with a trauma-informed care lens. I put this slide up because I have often run into people who have a misperception about what trauma-informed care means. And one of my first experiences where I learned a lot was presenting to a local police department. And it was very clear they had interpreted trauma-informed care as letting people off the hook, not holding them accountable. And I've since run into that. Many people still hold that perception, even if it's unspoken. Being trauma-informed means applying these principles to everyone, I believe, our staff, our patients, even our community partners, so that by adopting what I might call universal precautions, we assume that staff come with histories of adverse experiences. The bottom line is people are not trying to be difficult. They are doing the best they can with what they've got. And believe me, I've used that phrase in my head over and over again when I have felt frustrated with both staff and clients. So the intention was to treat our staff with the same principles we treat patients. Next slide. A bit about an overview of what an organizational structure would look like that is trauma-informed. And this is for you to take away and review later. It lays everything out that I've talked about in terms of the safety, the power, and the individual. So this is more of a schema for you to take away and look at and take back to your organizations and show them. Next slide. A little bit about Care Oregon. We're the largest Medicaid insurer in Oregon, and the Health Resilience Program serves the most complex high-risk population. The criteria for the program has been the Medicaid people we serve and some dual eligibles, 18 years and older. And the data that we use for a cutoff is to take a look at somebody is 1 inpatient admission and or 6 or more avoidable ED visits, non-OB. For the Care Oregon population, that brought in the top 5% of the people utilizing, having avoidable use of acute care services. And the other piece of our criteria is that it's voluntary, which is trauma-informed. We asked people if they want help from us with their health care issues. In addition, we are not working on a billable hour. We have time to build a relationship and build trust, which we believe is critical with this population with such trauma histories. Next slide, please. What we're all observing out there in primary care, safety net clinics, is that people aren't coming on. There are no-shows. People do not seem engaged with their care provider. Providers are upset with patients. Patients are feeling shamed or punished by their providers, not understanding how the health care system works. A lot of emotional reactivity from both providers and clients. Provider burnout, cynicism, and a lot of reactivity. And we also hear a lot in the labeling of clients as drug abusers or drug seeking. Going back to what Alex said is sort of what happened to this person isn't being asked. It's more about what's wrong with you, you're a drug seeker. So our whole healthcare system has gotten caught in a very reactive mode. which is not unusual. This population we serve are not only costing a lot because of utilization and the expense of that, utilizing acute care services, but they're being re-traumatized. Our very system is re-traumatizing these people, and much of what the Health Resilience Program does is step in and try to act like, I'd say, a couples therapist, trying to get a balance back between the two players, the clients and the doctors and the healthcare providers, whether it's community mental health or the primary care clinic, and have a conversation. We didn't think it was going to make a difference by simply adding outreach workforce to primary care, but a specifically trained workforce who could reach a population of people who have had repeated failures of care, a population filled with trauma experiences. We wanted a workforce understanding the impact of trauma and being able to recognize trauma behaviors and therefore be able to address and mitigate those. We also wanted to role model trauma-informed care behaviors to the primary care clinics to demonstrate how slowing things down and listening to people can actually help increase not only the morale and happiness with your job, but also people will tend to feel heard and therefore feel engaged in wanting to talk with us. Next slide, please. We've started. I'll start with creating safety. Keep going. You are on the right track there. Thank you. Creating safety, which is about, again, transparency, predictability, trust. If we expect staff to provide trauma-informed care, the workplace environment should be trauma-informed. We looked to hire at first, 4 years ago, bachelor's level people who had experience in healthcare. We started out with a couple of people with bachelor's degrees, and at the same time we found some master's level people wanting to work for us from community mental health. So we had an interesting pilot unintentionally that we started up from the very beginning with two different kinds of backgrounds. We used behavioral interviewing, which was really helpful in terms of identifying staff who understood the principles of trauma-informed care. Oftentimes we'll see people who don't use the language, per se, of trauma-informed care, but have the principles down. What we looked for with behavioral interviewing was that they weren't being judgmental, they weren't using labels, calling people, for instance, non-compliant or drug abusers, or showing more depth in understanding the problems with which this workforce, this population has. We didn't also want people who took sides, people who could remain neutral, not a rescuer, not directive, but to listen to people and be able to be, as I said, kind of Switzerland-like, neutral. Next slide, please. The ways we demonstrated valuing staff was to use the values of collaboration, mutuality, and again, applying non-judgmentalness to our own workforce and each other. We established a learning environment from the beginning. Our huddles included medical director, my director, myself, the health resilience specialists, and an opportunity to talk about clients and get ideas on approaches from each other. It was wonderful having this blended lens of the medical and the psychosocial brought together in one room, so that we didn't spend too much time on one or the other, but could look and understand our clients from both perspectives. In the weekly huddle, we also would work on our own trauma-informed selves, listen for our judgmental language, which inevitably pops out, and in an environment that no one's going to jump on you, but to be able to help us see when we are actually becoming judgmental and using judgmental language. So very challenging to do in a culture that has judgmentalness in every layer of it, but it was really helpful for us in terms of growing our program and being in a safe place to inform each other that we were sounding judgmental. We also started to include peer wellness specialists, which helped us, again, look at ourselves in the language we were using about clients. Valuing our staff also means providing training, recognizing the difficulty of the work, and I do mean the difficulty. Certainly when I have worked in community mental health, it is so fast-paced and there's so much responsibility placed on the shoulders of one individual, and I see the same in primary care. We can all relate to this, I know, that everyone's doing the best they can and running as hard as they can, and that taking time to sit and talk and connect to your fellow workforce, there isn't much time for that, yet that is what we draw on and the strength we draw on to do this work we do. We also started doing some off-site lunches with the group, going to have lunch and doing Qigong in the park, taking an hour and a half in the work week, providing time in the work week for the staff to build a relationship with each other and talk and share their struggles. Next slide, please. Over the first 2 years, we learned that the master's prepared staff, those with a psychology and social work background, were better prepared than the bachelor's level in some key areas. The master's prepared skill sets included training on trauma-informed care, mental health diagnoses, addictions, outreach, knowing how to be safe going into someone's home. Also setting goals with clients, which is really critical for us as we work with people from 6 to 9 months. We want to be very intentional about helping them set health goals that they can achieve and working with them. So having training in that is actually very, very beneficial. Also, the master's level people came prepared with more systems thinking and constructs, because we expected them to not only work within a primary care setting, but go out in the community and work independently and connect people to services that were needed across the community. This skill set was really valued that they came with. When I think of the third principle, restoring power, I think of the working experiences with staff again in the social services system and what I've seen in the safety net systems. There isn't much time to slow down and breathe, to learn more around how to stop and be able to listen to clients and what a difference that will make. Next slide, please. What you see here is some of the trainings that we've done for the health resilience specialists. The highlighted ones are in bold are ones that we do consistently and repeat. The others are just a smattering of what we provide. Valuing the individual, we are always asking our staff what they need to do their job better. It's not that we can always give it to them, but again, asking people what they need, trying to get it and or saying this is something we can do or this is something we can't has been very powerful. Providing the tools for them to do the work makes them feel valued. It also helps all of us in terms of the work and what we're trying to achieve. We have brought some of the clinic doctors that we're partners with in to help us and do specific trainings around diabetes, CHF, and that has been very valuable in terms of sort of mini trainings. Again, our staff have the psychosocial lens for the clinics. They get to go out and bring back what is happening with those clients who are not being successful to the medical system, who can't leave the 4 walls and only has training through seeing people for the most part through the medical lens. We also have health resilience specialists teach each other. We have a respiratory therapist on our team. We have an addictions health resilience specialist, and we recently added a housing specialist. I believe empowerment is about asking the staff what they need to do to get their job done to the best of their ability. Next slide. Another way that we check ourselves if we're doing what we think we're doing and there's a staff evaluation that's been done at Care Oregon, an annual staff engagement survey. Up here is on the screen is the 2014 result. And this goes back to creating safety. No matter how safe we as leadership try to make a program, many people come with trauma histories into this workforce and to this work. and even when given an open and transparent environment, can get triggered and fear authority and not speak up. So by doing this, we're able to kind of match, this is what we're seeing, and here's an opportunity for people who don't feel safe to speak up. Care Oregon utilized a professional survey which guaranteed anonymity. It asked questions about the work environment, manager actions, as well as what people felt about the organization. In 2013, our fully engaged results were 19%. Our engaged results were 71%, and our somewhat engaged were 10%. You can see the jump we made in 2014 there on the slide, in that we moved out of somewhat engaged, and those who were engaged even moved into fully engaged. What we found out is that we had set our salaries at more community mental health worker levels, master's level, which is about half of what medical master's level people make, social workers. And we went back to Care Oregon and said, we feel that there's a discrepancy, we're underpaying our staff, and they agreed and raised the staff's salaries significantly, which, as you can see, made people very happy. However, that is just one other aspect in terms of touching base with our staff and as to how we're doing. Next slide, please. In the past 6 months, we have added almost 13 new staff. Because our program has been getting a fair amount of notoriety, other primary care clinics have asked for health resilience specialists, and in other CCOs in the state, as well as needing to hire more people to support the team. This ramp up was really fast, and we started out with Care Oregon funding this. Then we've been on a 3-year grant, which is sunsetting June 30th. So Care Oregon is going to take us in-house as one of their departments now fully. There's been a lot of stress that's been going on here in the past 6 months. Leadership has been tested by this, and as have the health resilience staff. We've noticed the increased level of stress. Our old ways of communicating were not being effective. The model for seeking staff input as a group became unwieldy. Having a conversation and getting feedback with 30 people to 35 people was not being effective. With the communication breakdown, some staff became mistrusting of leadership. Despite our transparency, there has been an issue happening here of a little bit of mistrust bubbling up around the leadership. So for complete transparency with you all, I've been really having a hard time with that because of my intention to build a trauma-informed program. I've tried to be both curious and reflective this past month and not reactive as to what is off track and how to get back. Certainly the rapid growth was the likely initiating event starting in December. I also saw that I was the primary driver of having a trauma-informed program, and I should have shifted over the responsibility as I hired supervisors on. Having trauma-informed care policies and procedures from the beginning for the program would have been a perfect foundation to help staff understand this process. We only recently developed trauma-integrated supervision policy and procedure. So making sure that my supervisors are having conversations that are trauma-informed and talking about vicarious traumatization with our staff will now be put in place on a standardized way. In addition, having completed an organizational self-assessment for trauma-informed care would have helped provide a concrete roadmap. So stay tuned. There's more to learn, and I am confident we'll get back on track, but it has been a bump in the road that I have had to practice being trauma-informed and be curious and not reactive. And finally, last slide. I do believe we can't ask our staff to behave in a trauma-informed way towards our clients if we aren't practicing the same principles within our workforce. So I will stop here. Thank you.
Great. Thank you, Lori. So, Lori, we will now ask that you field a few questions from participants. So the first question is, for organizations that are just beginning to explore this field and want to become more trauma-informed and are really interested in implementing a trauma-informed care framework within their care setting, what's your biggest piece of advice, or what would you really recommend they get started doing now?
I would go back to what I wish I'd done in the beginning, was doing an organizational self-assessment. In other words, from the top down, looking at where, and you can find these at, I believe, the National Board for Counselors and Therapists, but I know SAMHSA probably has them too, of starting with a self-assessment, starting with what's the training that needs to be rolled out, and starting to identify policies and procedures around that, and have that structure, and then identifying, rolling out the information and the kinds of conversations that need to happen.
Great. And I guess a step before that, how did you create buy-in? How did you kind of get this started where you were at Care Oregon?
Well, the director who hired me and the medical director both had not heard as much about trauma-informed care, but again, we're one of those people that we all know out there, and some of us are who have operated pretty much that way in our work for a long time, being non-judgmental, being open, listening. And so they got it immediately when I started talking about it, and continued to encourage and support training staff in this way, encouraging staff to be this way, and basically role modeling how to be respectful and trustworthy. So it comes down to doing a lot of role modeling for people.
Great. And I know this program started 4 years ago. How were you able to get Care Oregon to take on the program permanently, or keep, sustain it?
Excellent. So data. Again, we sent out last fall. We were evaluated by an independent as part of the grant data analyst organization, and who looked at what we were doing in terms of utilization, and we did show that there was a trend downward. We were creating in both ED visits and inpatient readmissions. And also what was most powerful to Care Oregon was we did a qualitative study too. We sent out questionnaires to 10 clinics, asked the staff to fill them out about their experience with the health resilience specialist, and we had a resounding chorus of support from the providers saying that it made their job easier. They were better able to work with some of the clients that prior they had not been able to, and our program gave them hope. They had lost hope in some patients, which we all do. I know we all have had that experience when you're in it alone and see the work that the client is not doing for themselves. You do begin to get hopeless and that nothing will work or change their behavior. So I believe Care Oregon was most impressed with those factors that they were seeing from the self-reports of the physicians and the nursing staff and the MAs.
Great, Lori, that's really helpful. Thank you. So we have a question about how would you apply these lessons to a setting other than primary care, for example, to dementia care or other long-term care settings?
That's a great question. I would apply it the same way I apply it anywhere else. It is about training staff, and I have to add, the training of the staff, one of the key pieces that I think is really critical is the neurobiology of trauma, so that we help people understand that it's a wiring issue, and we tend to be more forgiving of people when we understand that they have some sort of a physical handicap, allowing them to not be able to do what we want them to do, and we don't always see that with trauma, right? So training staff in the neurobiology of trauma, which then starts staff thinking, they can't really help it. So they're behaving in a way that they need to manage and can learn to manage, but they don't get it right now. So applying those principles to a dementia setting, to any other setting, is where I would start. And the judgmental language. Describing someone as what I remember working inpatient psych, a goober, I think was a name someone used, or a frequent flyer. Immediately you get the impression that we've distanced ourselves from who that person is. I see that person in a different way. I don't see them as a human being when we start using labels. So labeling, I've found, and changing the labeling process has been a big stride for how we see people and how we interact. Great, and kind of along the same lines, are you having much luck getting primary care physicians trained and engaged, and how are you doing that? Does your training provide CMEs? Interesting. It's starting to take off around the state. I have gone to clinics where we have health resilient staff and done an intro to trauma-informed care, like in an hour, which is way too short, but they have asked me to come, and they're inevitably the people who are interested and get it right away, and so that sparks some discussion, as well as they have a health resilient specialist there that they can watch how they operate. So that helps, and as well, more and more organizations, Oregon Health Authority, other organizations across the state are providing access to trauma-informed care trainings for primary care physicians, and more physicians are starting to be involved in some of those trainings. So there's a groundswell happening, which is very, very exciting. Yes, absolutely. So we have a question about what is a trauma stewardship training? Actually, that was there's a book called Trauma Stewardship, and by a woman in Seattle, and Vandernoot Lipsky, the mouthful, and she's the one who goes out and does some trainings on the West Coast here and across the nation on trauma stewardship, meaning we have to take care of ourselves when we're in a workforce that deals with people who have high rates of trauma, whether you're police, mental health, primary care, social services, that we have to recognize our own triggers. We have to recognize that if we're getting burned out. It's accountability on the workforce and learning to recognize that. And her book is great. We bought one for all of our team members and have sent our team to her training. She does it very well with some humor and some understanding, having been there herself. And that's what the trauma stewardship is. And if you Google the book, you'll find it on Amazon. Great. And I know when you were talking about the Health Resilience Program, you might have mentioned this, but would love to get more detail about the types of trauma-specific treatment interventions used and what the format for sessions are with clients and groups and the number of sessions over time. Sorry, what was the first part of the question? What types of trauma treatment and interventions are used? So our whole model is, I call it pre-trauma work, in that our first job is developing a trusting relationship with somebody, which is very powerful. One where they feel supported, they know what it's like to work with someone who's not telling them what to do but can offer support. We can then open the door to them asking us questions about what might be more helpful. Building trust with someone, creating a safe space to talk, giving them choices. Do you want me to go with you to the doctor's appointment, or do you want me to sit outside? Treating the person with respect. All of those are trauma interventions on a very one-on-one basic way, and all have value. In essence, we're doing some pre-work so that people have a chance to, as I say, calm their amygdalas down and be better able to make choices and listen. So we do some meditation. We teach some meditation, which we do in our weekly huddle. We all do a 2-minute meditation. So we teach that to our clients, how to calm themselves, because that is one of the hallmark signals of trauma, is the reactivity. So that is some of the trauma work we do. In addition, for longer-term trauma work, we help them get into either community mental health, or some of the primary care settings have a seeking safety group. We've just started training a couple of our staff on that to hold those in the clinics, so we're experimenting with that also. So we don't do specific trauma interventions per se, other than trying to start the seeking safety groups in clinics. But what we are doing is the trauma work of helping people learn how to manage their reactivity and teaching skill building. Very basic.
Wonderful, Lori. So we just have a few more minutes for questions. So a question on funding. Outside of grant funding, are there other sources of funding for trauma-informed training programs?
What I'd say is other sorts. So we have Trauma-Informed Oregon, an organization that was just started up here, and they are going around the state providing trauma-informed care trainings. I do training for my staff. There are people starting to offer those services, but for free is a challenge. I think that's going to have to come from counties and state organizations who see the value of training their staff, the people in the workforce, to do this, because it is going to make for reduced utilization, and we're going to be able to help people actually change their healthcare behaviors by doing this. Does that answer your question?
Yes, thank you.
Okay.
So just, I guess, one last question. When you started 4 years ago, just a little bit more history, what were the biggest barriers that you encountered? And did they have to do with financing or staff buy-in or resources? Just to shed some more light on really getting this started. Yes.
The biggest barriers I saw were organizations that were in chaos, were traumatized. So the parallel process is that organizations mimic an individual's trauma behavior. So you look at an organization, if I see a couple of clinics that we started at that didn't work because you couldn't count on when a meeting was going to be. There was always a crisis happening. Everybody was running really fast so that there was no intentional slowing down process to be thoughtful. So there was so much pressure to hit billable targets that staff were just overwhelmed and basically really reactive. And I think that that's the hardest part, is getting buy-in from the administration, that it's okay to slow down, and in the long run, you're going to be much more effective if you can slow the reactivity down, just like with our clients. If systems can stop and think and be intentional about where changes need to make, which certainly is with the staff and staff morale. It's when staff stop feeling listened to or appreciated, valued, or they don't feel it's safe to speak up and say, I am so burned out and cynical, I need a day off, but I have to call in sick to have a day off. I can't say to my supervisor, I am about to hit the wall and I need a day off. So there are a lot of things that the system we can do, but that will open the space to have the staff start to feel safer to try different things and to speak up, which then will impact how they treat the patients. I have known organizations where the CEO is not trauma-informed at all, but everyone below them was. And they were able to push through an initiative to be a trauma-informed care workplace. So it can happen, but it certainly helps to have the those in authority have buy-in with it, because it does mean taking time to attend to your staff.
Great. I know here at CHCS, the work that we've done in trauma-informed care has really shown that staff is just as important as patients, and I think we tend to concentrate on outcomes for patients, and we have to realize that staff are important as well, so thank you. One last question that we've gotten several questions about. Do you have a dog as part of your team, and if so, what role does the dog play?
That is so great. I started bringing my golden doodle to work about 1.5 years ago, 1 day a week, and I just saw people's faces light up. And what we know is that what happens is endorphins get released when people get happy seeing a pet. And so I now bring her 2 days a week, and I bring her to the huddle and the team meeting. And I have about 60 people on this floor who now know Stella intimately, and she makes the rounds, and people, it makes people really happy. So yes, Stella is part of the team.
That's great. That's great. Thank you. All right. Thank you so much, Lori. And I will now turn it over to our next speaker, Victoria DeFiglio with Camden Coalition of Healthcare Providers, to discuss some of the work that they are doing within their patient population, as well as highlight some really innovative community transformation efforts taking place in the city of Camden, New Jersey. So Victoria, I will hand it over to you.
Great. Thank you so much for the introduction. And Lori, I just want to thank you for your presentation. Our team had a chance to go visit Care Oregon a while ago, and we left so inspired because the feeling of trauma-informed care is truly present everywhere you go, and people breathe it. So you've really made, you know, a model out of it and an operation out of it, and we came home inspired, and many of the things that you're going to hear me talk about are really reflective and echo many of the themes that Lori just said. So my intention today is to provide you with a context of what we do internally at the Coalition in regards to trauma-informed care, but also to share the Camden citywide movement around trauma and the energy that trauma-informed care has incited in our community. There we go. So before I do a deep dive into the Coalition's philosophy around trauma-informed care, I'll just start by providing a quick overview of who we are and what we do for those of you that might be new or unfamiliar with our work. We're located in Camden, New Jersey, which is an interesting geography in that it's a 9 square mile city with about 80,000 people, and it's the poorest city in the nation. I joined the Coalition 3 years ago when our staff was less than 20 people, and in just 3 years we've grown to 79 full-time staff. And our mission and vision is to improve quality, capacity, coordination, and accessibility of the healthcare system for all of the residents in Camden. And our vision is to be the first city in the country to bend the cost curve. And I'd like to draw your attention to the third bullet on the slide, which is that we're a membership organization with a 22-member board. And really what that means is that we have board members from the 3 competing hospitals in Camden, in addition to residents of Camden, local home health facilities. So it's a large stakeholder group, and it really allows us to get a broad perspective around both of our internal operations and also about our presence in the community. For those of you who might be unfamiliar, and just as a reminder about our organizational background, we work with the top 1% of patients who are the most vulnerable and the most complex. And this really came out of basically a data collation that our executive director, Dr. Jeff Brenner, completed, in which he discovered that 1% of the patients were responsible for 30% of the receipts here in Camden. And we've done that same analysis in city after city across the country and found that that same ratio holds true. And so the question he really wanted to know was, what happens if we go out and meet this top 1%? What if we go and we deep dive and we find out who these people are? And in the spirit of this webinar, I'd like to add that we're moving away from calling the folks in the top 1% superutilizers, but rather people with complex needs or people with the phenomenon of superutilization. Our intervention really started with Jeff going out to home visits as a primary care doctor. He started taking an interest in that top 1% of folks who he saw over and over again kind of cycle in and out of the hospital, and he often wondered what's their story. And so he started going out visiting patients with his office manager, which she still works with us as a community health worker. And slowly what they started realizing is that segmenting people by disease in an intervention doesn't always make sense, because what they realized is, you know, someone who has, let's say, you know, blood sugars that are consistently uncontrolled may look more similar to someone who has consistently uncontrolled COPD, but might look less similar to someone who has, very well-controlled blood sugars. That what made people more similar and what made it easier to develop a similar intervention was actually their pattern of utilization. That the pattern of utilization was a signal that something was going on, that there was a crisis. And so when we triage folks with complex needs, we're not doing so by disease state. We're really doing it by complexity. And targeting complexity means that we're taking into account traditional medical, mental health, as well as psychosocial and environmental factors. And early on in our work, we started recognizing that these folks with high complexity were telling stories over and over again of significant early childhood trauma. And so it started to be an area of interest for us very early in the work. In my day-to-day role in cross-site learning, I essentially have the privilege of talking to people all over the country who call us and want to know how we do what we do. And many people get on the phone and think that, we've figured out some magic formula or that we've figured out some magic bean in working, some sort of magic bullet to work with folks who are complex, vulnerable, very vulnerable and complex. And what I always have to tell them is there is no magic bullet, that this is actually really hard work, and that it's grounded. Certainly trauma-informed care is a pillar in that work and a pillar as part of our philosophy, but that also it's a broader care. It has roots in harm reduction, unconditional positive regard, and motivational interviewing. And at the heart of it is really this basic concept of acceptance and support of a person regardless of what the person says or done, especially focusing on the person as a holistic, patient-centered approach. And this is really at the core of how we do what we do. I echo Lori's ideas so much, and what Lori said really resonated with me, and the idea that you can't, essentially the parallel processing is at play. So we can't expect to treat our staff members one way and be super outcomes focused and very, concerned and driven with outcomes, and then expect them to go out and slow down with patients and, and be client centered and focus on the holistic picture. What we have to do as an organization is set up systems and set up management structures and signal through informal representations of values that trauma-informed care is present not only with our patients, but also in the broader organizational structure and philosophy. So I just want to highlight, I couldn't help but put up our core values and our people principles. Our core values, and I'll take a minute to talk about them, were really an organizational process. So from the ground up, people were involved in developing our core values. From the ground up, people were involved in developing our people principles. And I want to highlight some policies that we put in place as an organization that really reflect trauma-informed care through our everyday life. So one of the key pieces is that we have a $1,500 mental health benefit that's accessible to everyone on our staff. It's used in the form of a debit card, so it's not like EAP, which we often found that there was a lot of bias around going to EAP, that people felt, like somehow their employer was going to find out. Some sort of employee assistance programming, that they would find out that they had visited a counselor. So this is a $1,500 debit card, so even if your provider of choice does not take insurance, it swipes like a debit card and functions like cash. So it's completely anonymous. It can also be used for marriage counseling and for your dependents. So one of the things we found is that oftentimes on our staff, if people were struggling in their marriage or in their relationships, or if their child was struggling, they're not able to function and really provide therapeutic relationships with patients. So what we found is that traditional insurance benefits for mental health don't often cover those things in a plan, and that we found that in order to reinforce how important it was that people are present and therapeutic and trauma-informed, we had to make sure that they were okay at home. And so that was a structure that we chose to put in place. As Lori mentioned, we also, it's incredibly crucial that our folks have significant PTO available. So we have a generous PTO policy here. It's totally within our culture for a frontline staff member to go to their supervisor and say, I'm feeling really burned out and I really think I need the day off. And that's a conversation that we're used to having within the organization. We have tuition reimbursement, and additionally, tuition reimbursement, which many of our staff have used for things like mindfulness meditation training. So it can be kind of unconventional uses of tuition reimbursement. And policies and procedures around, what happens when a patient passes away? What is the policy around the organization? How do we memorialize that? What is the policy when someone expresses suicidal ideation, but not only for the patient, but also what happens to the staff member and how do we wrap our arms around them and care for them and make sure that they're doing okay. So I think that every day within an organization we represent informal values, and it's really crucial that, that these are part of what we live in trauma-informed care. I want to highlight a patient story to tell you what this really looks like on the ground. And before I do, I know Elizabeth is not on the line today, but I do just want to acknowledge that she's been gracious enough to share her story. And if you log on to that link, it will log you onto the NPR story in which you can actually hear her voice. And it's a very powerful story that really makes me emotional almost every time I hear it. She was part of our P3, which is a pregnancy program that our frontline nursing staff used to engage in, essentially where women who were pregnant would be in a cohort and basically participate in a group visit model. So as they went through their pregnancy, our frontline nurse would engage with them during visits leading up to their pregnancy. And this nurse had access to the electronic medical records at the hospital and would get flags every time one of our patients, had something happen. And so one day she logged on and noticed Elizabeth's name and noticed that when Elizabeth was 3 months pregnant and enrolled in the program, she had a dream, or she had visited the emergency room. And all the note in the emergency room said was that she was high on wet, which is PCP dipped in formaldehyde, and that she had smoked it and she was brought into the emergency room in an incoherent state. Her children were found wandering and picked up by DIFUS, and there was a note in the EMR that was incredibly hostile towards basically about her, about the situation, using a lot of labels. And Renee read the note, who was one of our frontline nurses, and basically went to Elizabeth and said, I'm curious as to what happened to you to get you to the point where you decided to smoke. And Elizabeth was so taken aback by the question that she told Renee a story that she'd only told 2 other people in her entire life, which was that she had a dream about past sexual abuse. And in order to cope with the dream, that was what she decided to smoke. It was an incredibly powerful moment for her because she described that no one had ever stopped and said to her, what happened to you? Instead, the frame was always, what's wrong with you? Why did you do that? What would have made you do that? Don't you know you're pregnant? Don't you know you have other children? And so what's fascinating about this story is that if you were to ask Renee if she's trained in trauma-informed care, she'd likely say no, in addition to the rest of our frontline staff, which was an interesting development as I started to prepare for this webinar. So she would likely say no, and many of the frontline staff, as I was walking around doing an informal poll, said, no, I don't think I'm trained in trauma-informed care. And I believe that, it goes back to an earlier slide, but as an organization, our stance really is that trauma-informed practice and care is part of a broader philosophy, and it's really not a standalone practice, and it's not a one-and-done, piece of information that you walk away with. It's really this idea of putting someone at the center of the relationship. And when I talk about relationship-centered care, I can't help but think about Michael. He was somebody who we originally engaged with very early on as a patient, and he had, when we walked in his room, basically the folks at the hospital said, don't bother. He's really difficult. He's never going to participate in your program. And it really just took Jason engaging with him at the front line and saying, tell me more about what's going on with you. It seems like you've been in the hospital a lot. And it was really remarkable to see Michael turn around, and what you're looking at is Michael actually doing his own care plan. And Jason, who's one of our nurses, spent 2 hours with him in his room, really learning everything about him and who he was and where he was in his life. And so this has really spiraled into a deeper practice of what we do at the Coalition, and part of our broader philosophy that trauma-informed care isn't standalone, that it's really about, it starts with the idea of building relationships, and when you ask our staff, they echo many of the principles in trauma-informed care, if not all of them. And I just thought it was interesting that so many of us, I think, in healthcare know the core frameworks and components of trauma-informed care, but might not use the language and say trauma-informed care. So I just wanted to highlight that, just perhaps because you don't do an ACE survey or, you're not involved in seeking safety training doesn't mean that you're not already practicing trauma-informed care. So I couldn't help but laugh walking around and preparing for this webinar and noticing that it's not yet part of our staff vernacular. So the current structure, I wanted to highlight the idea about ACE surveys. So ACE surveys, as many of you have heard of the Adverse Childhood Experiences Study, and Alex referenced it in the beginning of the webinar, we came, nationally, we're on this platform where we constantly are talking about trauma-informed care and the importance of it. And as a front, I started here at the Coalition seeing patients on the ground. Everyone who is clinical here at the Coalition has at some point touched patients on the ground, and we all breathe this. We get it. We know how important it is. And internally, we were still very much struggling with the conversation of whether or not to implement ACE surveys at the front line, because what we assume is that all of our patients have experienced early childhood trauma. So as of now, we don't universally administer the ACE survey, but what we did do this past spring is start a lean startup pilot where we assessed 9 patients with the Philadelphia Urban ACE survey, which any of you that are currently working in urban communities, I recommend you logging on. I've hyperlinked it here in the slide, but I'd recommend you logging on because it's an expanded version of the original questions of ACE. So it's an expanded version that is particularly attuned to folks who live in urban areas. And it was really remarkable. It actually elevated and expanded the list of questions, but also found that a large percentage of Philadelphians, over 40% actually, who are coming into emergency rooms reported 4 or more adverse childhood experiences. And the average ACE score was 5.6, which is quite elevated from the original survey. So that's something that we're working on, and we're in active dialogue. I wanted to be transparent about that and say that we're in active dialogue as a staff about whether or not to make that a universal part of our programming. Additionally, we're also deepening our trauma-informed care learning here at the Coalition, in that we're engaging in seeking safety training as well. One of the last pieces, actually the last piece I'll share about our internal approach to trauma-informed care is really that these are our domains of care planning. And so when you look across our domains of care planning, what you see is that very few of them are traditionally medical, or what I like to call below the neck. Instead, many of them are really psychosocial factors, environmental factors, or above the neck, or mental health support as we would know it. These domains of care planning came from incorporating MBAs with operational background into our frontline care teams. They led our care teams through a human-centered design process to understand all of the domains of what we do in our work with patients. And we really had to define what we do in order to make an operation of how we do it. When we're looking towards understanding, excuse me, how you make an operation out of a genuine healing relationship, it becomes very difficult to do that without understanding what you do and making a replicatable model. And now comes the fun part. So not only internally have we adopted a trauma-informed care approach at CCHP, but we've also seen a huge interest citywide among Camden, excuse me. So we've hosted 2 trauma summits, which drew hundreds of people, and I want to acknowledge really the organization that's at the forefront of this work in our community, which is HopeWorks in Camden. Father Jeff, who is a priest, recently left the organization as its executive director to pursue a degree in organizational dynamics at Penn. We're incredibly excited and anxious for him to finish that degree so he can spread more learning. But he really drove the conversation around trauma-informed care locally, and these trauma summits put national experts of trauma to discuss the neurobiology. He invited people from all different sectors, so the police department, healthcare, the Camden School District, hosts of other nonprofits, and leaders in these organizations. We had the chief of police at the trauma summit. Hundreds of people attended, and everyone's getting on the same page and getting engaged in dialogue and conversation around what does it mean to move a city towards trauma-informed care. From the first trauma summit, the energy and excitement was it was just overwhelming, that this idea of Healing 10 came out of it. And so Healing 10 is the idea of getting 10 organizations in a community involved in sanctuary certification, which is really leadership, so top-down, similar to what Lori was describing. It's an organizational assessment of how are we doing in trauma-informed care from the top down, and also, how can we then move our organization towards policies, procedures, systems that allow us to be trauma-informed. And so the idea would be to get 10 organizations, so healthcare, schools, the police department, any other nonprofits. How do we get at least 10 major organizations and sectors in Camden to become trauma-informed? And through this, so we have at least 10 organizations now at the table. I've listed the website there if any of you are interested in, seeing how it's progressing or replicating it in your community. We expect to impact over 1/3 of Camden's children and families in a given year if 10 organizations can become sanctuary certified and trauma-informed. That is profound. And so the Healing 10, will affect change by utilizing the sanctuary model of trauma, and the impact is expected on 3 levels. It's not only the city level, but the organizational level and also the individual level that Lori very much spoke to in her presentation. And lastly, where we're headed. We've signed a data sharing agreement with the local police department to cross-match healthcare utilizers with arrest and jail records. We found 200 overlapping individuals, which was very exciting. So we're now engaging in a pilot where we can essentially work with a few of those, so just a handful, 5 or less folks who overlap both systems, and target them in a really intensive pilot where we start to understand who they are and start to understand what does their everyday life look like. Additionally, we're in discussions with the Camden City School District to obtain data to start even further cross-mapping what that would look like. And so the idea of that is exciting to me, and as a city, I think that there's a lot of interest and huge amounts of buy-in and excitement around trauma-informed care because people see the effects that it has on the front line.
Great. Thank you, Victoria. So Victoria will now ask you a few questions that are coming in from the participants. So the first question is, what was the impetus for you all as an organization, Camden Coalition, for getting involved with the Healing 10, and how did that linkage occur?
Sure. So Father Jeff, has been talking about Healing 10, and HopeWorks in Camden, like I said, really helped to forward the dialogue in our community. So Father Jeff really already had a close connection and relationship with our CEO, Jeff Brenner, the primary care doctor that started our organization. So the two of them spoke regularly, and basically they started hosting community meetings. We decided and knew how important trauma-informed care was, and really made it a priority to be, not only a passive participant in those meetings, but really an active participant and really mold and shape the dialogue.
Great, thank you. Another question is, have you received any data around the benefits that you talked about at the beginning of the presentation around the mental health benefit and the paid time off for your staff? Just wondering about staff support.
Yeah, it's a great question. We've only been our own nonprofit since July of last year. And so we haven't actually been able to collect any data as of yet. It's very recent, so it's something that we'll keep you informed on.
Great. What are the next steps? So you mentioned you were looking into, you're doing seeking safety training. What are the next steps with you all regarding trauma-informed care within your organization? Are you, with this lean startup pilot, are you moving forward there? Are there other areas you might pilot, or are there other, other specific focus areas within trauma-informed care that you're looking to explore?
Yeah, I think, one of the big pieces that I want to emphasize is our foundation and our core and our, policies and really our workflow is all relationship-based. Everything is really about looking at the broader philosophy and the broader perspective of the patient. So when you highlight those care domains, so many of them are about not only just what's going on with you medically, but also what's going on in your life. And so by the nature of the way the intervention is set up, I believe that it's already trauma-informed. I think in terms of deepening, even greater expanding our trauma-informed care approach, the ACE survey pilot is certainly moving forward. I think that that's a broader conversation that our staff is really having and weighing out ethically with, and I think it's important to have those conversations at the frontline level and really engage in conversations around what are the pros and cons of asking every patient their ACE score. Because if the frontline staff's not engaged in it and doesn't believe in it, it's likely to not take off and have meaning. So it's really about creating buy-in at the frontline level and having them really give their feedback and inform, what are their concerns, what do they see as positive. One thing I will say is that the early results of the pilot really did inform that folks really do believe that it improves the provider-patient relationship when the provider is more informed of the patient's ACE score. So I will say that that's been a huge positive. And then the seeking safety training, and we're constantly engaging with HopeWorks and learning about the trauma triangles, how trauma affects not only patients but organizational dynamics as well.
Great. So I think that's something that we've found here at CHCS in our work as well is it differs by organization. So an organization, the way that they approach trauma-informed care may look a little bit different from another one. So we've heard from experts that it's really, it's up to an organization how it's implemented and brought out and viewed. So I think we echo that as well. So this is a question for our first speaker, Lori, as well as you, Victoria. What are your thoughts about administering ACE studies to staff? And Lori, I know you talked about hiring and staff support as well, so would love for either of you to jump in.
Well, should I go, Victoria?
Sure, go ahead.
Okay, so my first thought is that I don't see that for our staff that's necessary. I think what I've done in some of my trainings is there's an application you can use where I ask people in the audience to read the ACEs survey and then text to a certain number what their ACE score is. And so that the audience can see up on the screen, and this is an audience of professionals, the number of people with ACE scores, usually, 4, 5, 6 in the audience. And that's a powerful tool for staff to begin to understand that we work with colleagues who have ACEs scores. I don't know that it's necessary to do that with staff as long as we're all having the conversation around being triggered, that the supervisor is intentionally having conversations with their supervisee around how do you take care of yourself when Jane comes in? What happens when you start getting reactive with her? You were talking about that the other day. How do you know and how do you calm yourself down? So I think what's most important is that people feel safe to talk about it and it comes up in a conversation easily, but supervisors have to intentionally be alert to that and listen for it. Besides which, doing this as long as I've done it, I can tell if someone has an ACE score by some of the behaviors and comments they even make and their reactivity. So, Victoria, what are your thoughts?
Yeah. So we do something similar in all of our trauma-informed trainings as well. We've done it both ways where we've had people read the survey on the spot, and actually at all of the trauma summits, that's been part of the agenda, is that people actually read the ACE survey to themselves and give themselves their own score. We've certainly been in situations also where it's been up on the screen. I also don't believe it's necessary to do with folks. I think that I go back to the same thing that you're saying is the management structures that exist and that are in place have to allow space for managers and employees and even employee to employee to have those dialogues and conversations, and have to allow time and room and space and give weight to that when you're seeing behavior that's coming up that's clearly, you know, maybe emotional triggers, or that someone's really struggling, that is a transparent dialogue that people are seeing and that it's out in the open and that it's not being shoved down. Because I think as soon as you start to lock it down and emotions are, you know, seen as something that's bad, outbursts are seen, you know, in the really negative light, I think that starts to breed a toxic culture. So I think that it really goes back to the way you implement your management structure and making sure that your managers do have time and space to be with their folks and really address that stuff head on.
One other thing I'll tag on, which I bet you would agree with also, Victoria, is that we see that trauma is basically a public health issue. And much like when AIDS was being talked about, the longer something's a secret, the more power it has. So being able to talk about it and normalize it is so powerful. And it is a public health issue. So why not be able to talk about it? And yet we're also doing something new, and people have to feel a certain sense of safety to talk about personal and private things.
Yeah, I totally agree.
That's a great point, Lori, and actually you answered the next question we had for you. So I'll ask this to you, Victoria. How do you see the concept of trauma-informed care spreading? So Lori mentioned it's a public health issue and there's, you know, more awareness and so forth. What are your thoughts around that?
So I started doing this training probably in 2005, and what I've seen is barely anyone had heard of the ACEs study then. And since then, and I'd say in the past 4 years, I have just seen the level of awareness and understanding take off. So I think people are recognizing in the medical world as well as social service agencies that here is something that can help us do our work. And we are seeing results. People are actually more willing to be helped. We can now reach people that we weren't able to reach before. So it seems to be spreading by word of mouth because people are having really good results with it and experiences. So I think opportunities to bring it up with colleagues. Have you heard about the ACEs study? Do you know about the neurobiology of trauma, that people who are screaming at our receptionist, they don't know any better. No one taught them the skill about how to get what they need. So let's train our reception to be better prepared to work with those people.
Great. Thank you, Lori. Victoria, we'd love to hear from you.
Sure. I think I echo what you're saying. I walk into rooms now and people have heard about the ACE survey, which is a huge difference. I completely agree that that's really a marker that trauma-informed care is taking off. I think the other piece is really this idea of more movements like Healing 10. So I think within our own community, it's been incredibly powerful that, you know, something like Healing 10 has brought together the chief of police, who's sitting next to the superintendent of schools, who's sitting next to the CEO of a hospital here in our community, who all are really bought in and engaged in figuring out how we implement trauma-informed care, through organizations, and particularly organizations that really address and come in contact with children and families who are often in vulnerable situations. And so I think, I have to say, I think at the organizational level and top-down, that can't be replaced in terms of what it does for a community and what it does for people in that community, not only who are residents there, but also people who work there, to start to live and breathe the philosophy.
Great, thank you. All right, thank you both, Victoria and Lori. A few closing remarks before we adjourn. The slides and a recording from this webinar will be available on our website shortly, and an email announcing the posting of these materials will be sent to all of the participants on today's webinar. We ask that all participants complete a very brief online evaluation, and this will pop up on your screen after the webinar is done. Your feedback is very important to us and will really help guide future CHCS events, so we thank you in advance. And lastly, we want to thank Kaiser Permanente Community Benefit for funding to support this webinar, as well as a big thank you to our speakers, Lori and Victoria, for their wonderful presentations. And thank you all for participating today, and we hope you'll join us again soon.
Thank you.
Thanks so much.